Well said. Well, good morning, everyone. Welcome to AIDS Clinical Conference. It's my pleasure this morning to welcome our speaker, Dr. Jihan Budek. Jihan joined the University of Washington as an acting assistant professor last year and is already doing remarkable work helping lead the HIV clinical and teaching programs. Dr. Budek graduated from Yale University before attending the University of Washington for medical school residency and chief residency, and then departing for UCSF, where she completed an ID fellowship and essentially captured all the teaching awards that they offer. We were delighted to recruit her back to Seattle, where she is currently the assistant medical director of the Madison Clinic, director of the HIV pathway in the residency program, and director of the medical student course in clinical HIV care. Jihan is an extremely talented clinician and teacher, and this morning will speak on the care of the newly diagnosed patient.
Okay. Mic up. Okay. Is this working? Yeah, okay. So thank you, Bob, for the introduction. As he said, my name is Jihan, and I'm going to talk about the sort of controversies that come up when caring for a patient who's newly diagnosed. And we had a bunch of poll everywhere questions which aren't working, so I'm going to ask for people's hand raising and audience participation if possible. So I have nothing to disclose. And by the end of this sort of hour, I hope that we will have discussed rates of transmitted drug resistance and its impact on baseline resistance testing, discuss data for same-day ART start, and then also describe the 2019 updates to the DHHS ART guidelines, and interpret the data regarding dolutegravir 3-TC use, which is a new combination pill called Dovato. And so to mirror that, we're going to go through the talk in about 3 sections, starting off with transmitted drug resistance, same-day ART start, and then what to start. So to begin, transmitted drug resistance is when an ART-resistant virus is transmitted from a patient or a person who has HIV to a person who doesn't have HIV. And so we're going to abbreviate that as TDR. And this comes up when we are seeing a patient for the first time and trying to figure out what baseline resistance testing to test for. And the reason why this comes up is that there is, the DHHS guidelines recommend testing, getting a baseline genotype. And so how much transmitted drug resistance do we see? And I thought we could talk about that sort of over the past couple of decades. So transmitted drug resistance worldwide, this is a map of TDR rates in men who have sex with men. And as you can see, sort of the ranges go anywhere from 2% to about 15%. Here you can see it seems that in Australia we have a fair amount, and then followed by the US and East Asia. Here we don't really have any rates for MSM, transmitted drug resistance, in Africa, but we do have data regarding transmitted drug resistance amongst heterosexual populations in sub-Saharan Africa here. Now I looked at that, and there's some other data more recently that shows that the actually TDR rates in Africa are about 10 to 23%, just for an example. And in the US, really, we're talking about 8 to 15%. Then I wanted to show this slide. It's a little bit of a busy slide, which talks about temporal trends in transmitted drug resistance in Europe over about close to 20 years. On the y-axis, we have prevalence of transmitted drug resistance, and on the x-axis, we have years. And really, it has transmitted drug resistance in general, and then broken up based on the class of ART. And really what I want the takeaway point from this to be is that with time, hopefully you can see that there's a slope that's going down and that transmitted drug resistance is decreasing over time. And that's like multifactorial, but a couple of the reasons are that we have better meds with higher barriers to resistance, and so thus people aren't picking up resistance and then spreading it. And what about in the US? So this is a graph that's a little bit older that shows TDR rates in the US from 2006 to 2009. I'd like you guys to draw your attention to the far yellow bar, which is sort of all cases. And then on the far left, you'll see that these are the rates of transmitted drug resistance to either one class or two classes. And here it has about 15.6% as the TDR rates in that time frame, which is about what we expect. And then as you can see on the far right, it breaks it down based on class. So with the most transmitted drug resistance seen in NNRTIs, followed by NRTIs, and then followed by PIs. And this mirrors the rest of the world as well. So that's sort of older data. Do you routinely order a baseline integrase genotype when seeing a patient with HIV for the first time? Answers are yes, no, and sometimes. And I was, again, hoping this would be anonymous, but anybody for a yes, always ordering a baseline integrase? No? Okay, we've had a few people saying no, and then how about sometimes? So that's me. And so I don't know if people saw, and then as far as the webinar goes, I can just mention that nobody said yes, a couple people said no, and a couple people said sometimes. So can I ask those people who do it sometimes, sort of when do you decide to do it? Anyway, David, I'm gonna pick on you. Sorry, yes. You.
So what if you knew that their partner had integrase resistance or had been failing on an integrase-based regimen? Or so one option would be is if you knew their partner that likely was the person that transmitted them had integrase resistance. Or the second thing that I've done is if there's multiple classes of resistance, I've ordered it then, because I think then you really have a lot of limited options and you'd really want to know up front.
And so that's like if you know that their partner has multi-class drug resistance.
Or even if you knew that, or if you knew they had failed an integrase-based regimen.
Certainly, yeah. I think, I can't say that I do it with like consistency. I think I sometimes do it based on feel, which is not a great way to do things, though sometimes not wrong either. And so I just thought that we could go over some of the data as to like, where are we with sort of INSTI resistance? And the DHHS guidelines have recommendations for antiretroviral therapy naive persons. And this is a little bit busy, so I'll take you through what they say. So they say that HIV drug resistance testing is recommended at entry into care for persons with HIV to guide selection of the initial antiretroviral therapy regimen. They say that in persons with acute or recent HIV, in pregnant people with HIV, or in people who will initiate ART on the day of or soon after HIV diagnosis, that ART initiation should not be delayed, and then the regimen can be modified once results are reported. And then lastly, this is the part that I think leaves room for discussion. Standard genotypic drug resistance testing in ART-naive individuals involves testing for mutations in the reverse transcriptase and protease genes. If transmitted INSTI resistance is a concern, it says to ensure that genotypic resistance testing also includes the integrase gene. So again, we sort of asked David sort of when he is concerned about this. I shared that sometimes I do it based on feel. And so I just wanted to talk again, like how concerned are we about transmitted INSTI resistance? I think before we go into that, since we were talking about timelines and trends, it would be a little bit helpful to see where are we with INSTIs and sort of how long have INSTIs been around. And so the first integrase inhibitor was raltegravir, which was FDA approved in 2007. There was a pretty long, big gap. And then we saw elvitegravir and dolutegravir FDA approved in 2012 and 2013. And then lastly, bictegravir FDA approved in 2018. The reason why I think this is important to show is that some of our older ART regimens are older. And so we have more data on NRTI, NNRTI, and PI resistance, but we just don't have as much with the INSTIs. One, because they are a relatively potent class of medications, but also because they're relatively new. So is transmitted INSTI resistance a concern, as talked about? So there's a couple of cohort studies that I thought I would mention. One was a UK cohort of 101 ART-naive individuals from 2010 to 2013, so after raltegravir was on the market, but before pretty much before the others, and no major INSTI transmitted drug resistance was detected in that group. Then there's actually the US cohort, it's the sort of the UW's HIV registry cohort of 82 ART-naive individuals, and in sort of a 2005 to 2013 timeframe, no baseline INSTI resistance was detected. I think that this Santa Clara County cohort might mirror us a little bit better. That is a sort of their county HIV clinic, and they looked at 206 ART-naive individuals from 2006 to 2013, so maybe sort of similar to Madison Clinic, and they found that their overall transmitted drug resistance prevalence was 17.5%, and that there was one person who had INSTI transmitted drug resistance with a prevalence of like less than 1%. And that was an E138A. And then lastly was the Swiss cohort. And this is sort of the biggest data we have about this, of 1,300 individuals who are ART naive. And again, similarly, one INSTI transmitted drug resistance case was seen, and that prevalence was also 0.08. So low rates being seen in these cohorts. Again, sort of trying to figure out like how applicable is the Swiss cohort to Seattle. I'm not exactly sure. Perhaps a different patient population, but I just wanted to share some of this data. So then what about case reports of transmitted INSTI drug resistance? I was able to find 4. So first was a case back actually in 2011 of somebody who had a transmitted drug resistance, which they actually sort of went back, got their sort of blood from before ART was drawn, and then added on INSTI genotyping, and they found an N155H and then some other polymorphisms. So this is sort of resistant to especially the early generation INSTIs, but also potentially to the later generation INSTIs, which are dolutegravir and bictegravir. Similarly, there's another 2 cases that had the same exact resistance profile and had multi-class drug resistance. Again, people were not getting baseline INSTI genotypes, but these were sort of found after the fact. And then lastly, I think the most recent article, which is actually entitled Canary in the Coal Mine, was of a case of a woman in her 40s who had actually baseline genotype being obtained for NRTIs, protease inhibitors, and INSTIs, and they found multi-drug resistance to integrase inhibitors and also to some of the NRTIs. Subsequently, they found out that this person's partner had this same drug resistance profile. So that's that. Trying to sort of figure out who these people were. There wasn't really much of sort of like a story or an association that I could figure out with how will sort of their stories impact me getting my integrase baseline resistance testing, but this is sort of what we know so far. And then I think that a little more helpful and a little bit more, I guess, current is information from a poster at CROI in March of 2019, so just last year. And this was a group where they looked at 23 US jurisdictions throughout the US, and the states were sort of all over the US, so pretty well represented, with the exception of maybe the like middle top of America. And they found that there are 36,000 cases where baseline genotyping was obtained, and their TDR prevalence was 19%. So again, sort of where we might expect for the United States. And then of about approximately 5,000 people who had INSTI baseline genotyping done, they found that 42 people did have transmitted drug resistance to the integrase inhibitor class with a prevalence of 0.8%, which we're also seeing based on some of the other cohort data that I shared. So overall, they found that TDR prevalence was stable from 2013 to 2016. And what about INSTI transmitted drug resistance prevalence over that same time frame? And here you'll see that over those 3 years, there was a little bit of an increase. It was statistically significant, but in the year of 2016, they found that TDR rates were 1.1%. I also thought this was a nice study because they looked at the prevalence of specific transmitted drug resistance mutations by drug class. And I sort of have this up here as a sort of as a reference or a resource if people are interested. And so now, based on that information, sort of the data that we have, will you order baseline integrase genotypes as part of your practice? Yes. Okay, we haven't changed anybody's idea, sort of thoughts on that. No. Still a no. Brian is still a no. And then sometimes, I think we're, okay, so it feels like I might have swayed Anne to the sometimes range. Anne, can I also pick on you? And I'm sorry for that, but what made you sort of change, and what are some situations now from?
Well, I think the idea of if you knew that someone's partner had multi-drug resistance is a really good idea. So I like David's idea. I can't say that I've seen somebody who had new HIV who had a clue where they got it. So I think my answer is generally no, but I think there are probably circumstances where it would be really appropriate. And the thing about prevalence data for resistance, if it's not done well and you're taking a huge population, the people who, if they're taking like who's had integrase done, those are probably at higher risk for having integrase because those are the people who were ordering the test. So 1%, if it really is the higher risk group, is still very, very low.
Mm-hmm. And then Nina and Brian, can I ask, you guys are stuck to the nose. Can you describe that?
For me, I'm still left unclear as to what a lot of these mutations were found, like it sounds singly or maybe doubly, or
Yes.
like, yeah.
Yeah, mostly doubly.
Yeah,
or
I'm still
triply.
left with the fact that, in order for you to have dolutegravir not work, which is really kind of one of our mainstay integrase transcription inhibitors, is you have to have a number of these mutations. So I'm still grappling with the clinical significance of these mutations, because some of these mutations may just be genetic polymorphisms that you happen to have picked up, and Anne's point that you're actually dealing with sort of some selective testing rather than, so I'm not clear what the true estimate of INSTI resistance prevalence is. And so because I'm not clear, and because I'm not clear about clinical significance, it's not going to currently change my practice.
Yeah.
Yeah, I mean, I think everyone's maybe, I mean, the fact of the matter is it's very rare. I mean, your data is showing that it's very, very rare, and that 1% may be an overestimate. So based on that,
And I think I also wonder, sort of as time goes on, will we see more of this, or are the meds so potent that we actually won't see more of this? And so I think that is something that I'm wondering. And then I know Brian and I were sort of chatting about this, but there's some cost-effective data or cost-effectiveness data around this. In 2017, Rochelle Walensky's group in Boston looked at the cost-effectiveness of INSTI baseline genotype testing, and they found that it was not cost-effective, and that it cost on average sort of $200 extra per person per year, which isn't really, to me, that much money when I'm sort of trying to evade INSTI resistance, but I just did think that was interesting. And then more recently in 2019, they came out with a sort of a similar cost effectiveness analysis looking at just baseline genotype testing in general. So for reverse transcriptase or protease resistance. And they also found that that was not cost effective. And I think that's interesting because if you think about it, the sort of TDRs that I've seen mostly are a K103N, an M184V, or a couple of TAMs. And we actually know that based on the Donning data that we can use tenofovir or like TAF, FTC, and dolutegravir or Biktarvy against those resistance mutations and actually have good efficacy. So that is something else to sort of consider. And I wonder, are there anybody in this group who even wonders, should we be getting baseline genotyping at all? Nina, Brian, do you mind just sort of like elaborating a little bit on that?
Apologies to public health who uses them for contact tracing, but I just wonder if they are necessary and cost effective now that we are starting nearly everyone on dolutegravir or Biktarvy. And in terms of the transmitter resistance, I see 3 case reports of transmitter resistance that would significantly affect those drugs. So I just question the necessity and the cost effectiveness. And I feel like if a person starts dolutegravir, Biktarvy, and their viral load is, and they're taking it and their viral load is slow to respond, if we do resistance testing at that point, I don't see a clinical downside.
And I think one of these cases, I think it might have been the second or the third one. I thought it was interesting because, the fourth one, which actually is like a pretty significant sort of mutation profile against INSTIs. They actually got baseline genotyping, as I mentioned. They started the patient on medications. 3 or 4 weeks later, that baseline resistance result came back. They saw this profile, and then they changed the patient to a different regimen. However, we don't really have data on what their viral load was at that time. And I just think that's interesting because to start off with, their viral load was 216, very low to begin with. And so I just wonder, I mean, I would not keep somebody with that sort of resistance profile on an INSTI-based regimen, but I'm just curious, like, what happened in that first 4 weeks? Granted, we know with sort of INSTI monoresistance data that eventually at least 24 weeks things look okay, but then at 48 weeks things start looking bad. But I just thought that was interesting, and I would have been really curious as to know what that viral load was 4 weeks in. And thank you everyone that I picked on for sharing your thoughts. Okay, so moving on to same day start. So I think I initially started calling this like when to start, but we all know to start sooner rather than later. I'm not going to go over that data, but I did want to talk about starting right away. So I changed the question to how quickly should we start ART? And the DHHS guidelines recommends initiating ART at the time of diagnosis when possible or soon afterwards to increase the uptake of ART, to decrease the time required to achieve linkage to care and virologic suppression, and to improve the rate of virologic suppression amongst individuals who have recently received HIV diagnoses. So as soon as possible, within some reason. I think they give us that sort of caveat when they say when possible. So I wanted to know what data exists for same-day ART start. And I know that Shrisha Dan already recently went over this in an echo, but I thought that we could review some of this data. So some of the first data actually comes from a study in South Africa, and actually in a sort of HIV clinic in Johannesburg, where they randomized approximately 300 people to either standard ART start or the rapid start, which is the day of that visit. And as you can see, this curve on the y-axis is percent initiating treatment, and on the x-axis is time to treatment initiation. Red is standard arm, blue is rapid arm. That you'll see that people in the rapid arm were started on medication much sooner than the standard arm. In addition, although you may say, okay, great, Jihan, they started it sooner, like how does that affect their virologic suppression rates, or I guess rather their sort of adherence to medications? Within 1 month, 96% of individuals, as you can see this here, or within 1 month, 96% of individuals in the rapid arm were on ART, as opposed to 58% within the standard arm. And then at 10 months, 64% remained on ART in the rapid arm versus 51% in the standard arm. So there's some data from that. Similarly, there's some data from Haiti. This is a bigger group of 700 clinic-based individuals with HIV who were also started on either sort of their regular standard of care ART, which is relatively soon, versus same-day ART. And their primary endpoint was retention in care in 12 months. And so again, on the y-axis is the percent retained in care, and on the x-axis is days after enrollment, so going out to about a year. Standard ART is the solid line, and then the dotted line is the same-day ART. And as you can see again, the dotted line is higher, and so thus more people were retained in care at about 12 months in the group that was started that same day. And then a little more locally, San Francisco tried or has done this rapid ART program, and they initially piloted this and then shared this data from 2017. Where they started this rapid program. I think what I can at least mention about the rapid program before sort of talking about this graph is that it is very resource intensive. So you find out somebody has a diagnosis, they have partnered with Uber or Lyft to get the patient to clinic. The social worker, finance, physician, nurse, all get together. It's almost like a code. Somebody comes and then labs are drawn, counseling is given, and a starter pack is given. So that is how sort of the rapid start goes, and that's what they started off. And I think in 2017, this is the data that they shared. On the y-axis, again, is proportion of people who are virologically suppressed and versus their time in clinic. And as you can see in the rapid ART group, it was sooner as opposed to universal ART or when people would be sort of regularly started on ART, and then as opposed to CD4 guided ART, which we have stopped doing a while ago. Then they decided to make that pilot standard of care. And then they sort of published some of their data from that just last year in 2019. And they found that over that time period, 225 patients were referred for rapid start, and that was a 4-year period. And 96% were actually started right away. They found that not surprisingly, the time to suppression was less. So 41 days to a viral load less than 200 and 58 days to a viral load less than 50. Which again makes sense. If you start ART sooner, you're gonna hopefully suppress sooner as well. And then they followed them up and they found that about 96% of individuals achieved virologic suppression at 1 year. And then over a median of 1.09 years with a range of 0 to 3.92 years, 92% achieved viral suppression. I'm sort of curious as to know what happens from here on out as well. And so to summarize some of those results that I shared with you, the rapid RCT in Sub-Saharan Africa and in South Africa showed that offering a single visit ART initiation to adult patients increased uptake of ART by 36% and viral suppression by 26%. In Haiti, we saw that same-day ART initiation improved retention and care and virologic suppression at a year. They also did some qualitative sort of data and showed that starting ART right away increased hope and connection to care. And then in San Francisco, we saw that time to suppression was quicker, but that it was resource intensive. And so I think that resource intensive part is really critical, especially for those of us who are in clinics. I think this is, sort of something to strive for, but maybe not actually feasible. And some of the barriers that came up from the Haiti study were wait time in clinic, especially sort of starting right away. I can imagine in San Francisco too, the patient would come and it'd sort of be a whole day of fare to get them started on ART. Transportation and costs. This clearly requires on-call clinicians, social workers, RNs, pharmacists, counseling. Insurance coverage is a big issue. And luckily in San Francisco, I know they were able to sort of partner with at least Gilead to get their starter pack, but that's one thing, and that these are resource intensive endeavors. And to sort of really highlight that, I just want to show some of the study protocols from both the Haiti and the South Africa study. And so this on the right is the same day ART initiation, on the left is standard of care. I don't want people to read everything on here. It's just that as you can see on the same day ART, all those things are sort of scrunched up more in the first day or second day or third day. And then in the South Africa group, you can see all the things that happen in visit 1 on the right in blue, which is the rapid initiation, as opposed to what happens in standard over a time course of 6 visits. And so same day ART conclusions from the DHHS are that, quote, whether rapid initiation improves long-term care engagement and virologic suppression is not yet known, especially because, as I mentioned, we don't have that much sort of RCT data from America. We have this pilot from San Francisco that we have some information from, but no RCTs. And then they say, quote, while the infrastructure and resources necessary to implement an immediate ART program may not be available in all healthcare facilities or settings, removing structural barriers in order to facilitate rapid ART initiation may improve outcomes in the United States. So I wanted to ask, if resources and finances were not an issue, would you do same-day ART start? Yes, no, or maybe. So who's yes? Okay. Who's a no? Nobody. And who's a maybe? A lot of people didn't vote. Okay. Anybody? There are no maybes. I mean, I think it'd be great if we could do this. I think I just recognize that it's really resource intensive. Have people sort of come across this before, at least talked about this at their workplace? Brian nods. I'm going to pick mine. Anne, yes.
Well, we had a study where we did same-day ART for unit. It was incredibly time intensive. Sorry. So we did a study where we did same-day ART for several years, and it was incredibly time intensive. So it's possible, and I think if the patients are willing, I think it's a great idea. Obviously, there are some patients who just don't want this at all.
Right.
And they are the ones, and that would really be the maybe in my mind. I said yes, but because I try and persuade people it's a good idea. But clearly, if someone is not willing to do this, then we're not going to strong arm them.
Right. We can't force someone into it. And I think in the South Africa study, some of the reasons why people didn't do the rapid start were patient preference. And it was a small percentage, but it is still something to sort of highlight again. And Anne, thank you so much for mentioning that, is that, we don't want to, we obviously want to encourage and recommend strongly, but if the patient doesn't want to do it that very day, again, a very small percentage, don't really want to strong arm a patient. But again, that was an extraordinarily low percentage. It was lower than lack of electricity as being a reason for them to not get their ART start. So Bob, I'm going to pick on you. Do you think this is something that we might be sort of going towards with time, like in the next 5 to 10 years?
Yeah,
Or
I think maybe the most compelling part of maybe the most compelling data is they stay engaged in care over the long run, better than people where you don't start ART on the same day. So I'm not fretting so much about, does it make a difference whether you started today or whether you started a week from now or 2 weeks from now clinically, unless they have primary HIV infection. But I think you hook them. And if you send somebody out with some pills and they have to take these pills every day, then I think they're more likely to stay engaged in care. They take it as, oh, this is serious, I need to be on these medications. And I think their long-term retention in care is better. At least that's what the studies show to my eye. So I think it's a good idea when we can do it.
thank you. Okay. And then to sort of finish off these controversies when you're starting somebody on meds or seeing somebody for the first time is what to start. So the sort of DHHS criteria or guidelines have these recommendations for initial regimens for most people with HIV, and I'll take you through them. And I'm going to sort of read a fair amount of these things. So first it says these recommended regimens are those with demonstrated durable virologic efficacy, favorable tolerability and toxicity profiles, and ease of use. And so these have been the recommendations for a little while. The top 4 were either Bic/Taf/FTC or Biktarvy, dolutegravir, abacavir, 3TC, dolutegravir plus a tenofovir-based regimen, or raltegravir plus a tenofovir-based regimen. Now you'll see that there's a star next to the dolutegravir, abacavir, 3TC, which is saying that this is only if you're HLA-B5701 negative, which we know takes a little while to come back, a couple of weeks. And so that's not something that we would start on somebody right away. In addition, you may not know their Hep B status. So that also might require a star. And then I wanted to mention that on December 18th of 2019, so about 2 months ago exactly, that this was a new recommendation, that an INSTI plus 1 NRTI is a recommendation to start in, quote, most people. There is some fine print, and I know that some people have seen this data already, but I think it's important to go over that dolutegravir and 3TC, or dolutegravir and lamivudine called Dovato in combination, can be used except for individuals with an HIV RNA greater than 500,000, with HBV co-infection, or in whom ART is to be started before the results of genotype resistance testing for RT or HBV testing are available. So there's a long caveat there. And those are the DHHS guidelines. I wanted to sort of just highlight and contrast the fact that there's another set of guidelines as well. There are the IAS USA 2018 ART guidelines, and these are guidelines that come out. They're obviously not updated as frequently as the DHHS guidelines. And as you can see, these are from 2018. But I did want to mention that even before this most recent update, there was a slight discrepancy. You might remember from the previous slide that there were 4 initial options at the top right here. And then here they only recommended Biktarvy, Triumeq, or dolutegravir plus Taf/FTC. And I suspect that was because raltegravir has a relatively lower barrier, or has a lower barrier to resistance than these two. But I just wanted to highlight that even before these new updates, there was a discrepancy in recommendations. Then in the DHHS guidelines, it goes into more details. What about certain patients or specific patients? And then I wanted to highlight this because we're sort of imagining our patient right now who's coming into clinic, and we're sort of deciding what to start this very same day, if we can. And the clinical scenario says that ARV should be started before if ARV is going to be started before drug resistance results are available, or when ART is being initiated rapidly, to avoid an NNRTI-based regimen and dolutegravir 3TC. It's highlighted in yellow because these are new. To avoid abacavir, and then it gives these recommended ART regimens. So let's go through the reasons why that's the case. So they say to avoid an NNRTI-based regimen. They give a rationale that it says transmitted mutations conferring NNRTI and NRTI resistance are more likely than mutations associated with PI or INSTI resistance. We know that from the first section of this talk. And so thus, you wouldn't really want to start off an NNRTI since we do see higher rates of transmitted NNRTI resistance. But in addition, some medications such as rilpivirine require somebody to have a viral load less than 100,000 and a CD4 count greater than 200. And so we're not going to have that information on that same day. So avoid that. And then avoid dolutegravir and 3TC. Sort of the main reason that they're highlighting here is that what if there's NRTI resistance? Again, an M184V, which is a reverse transcriptase mutation, is relatively common in the transmitted drug resistance sort of scheme of things. And so if you do that, you lose 3TC, and so thus you just have your patient on one effective ART. And then similarly, to avoid abacavir, because HLA-B570 results may not be available. And then in the far right, it says transmitted resistance to darunavir, Biktarvy, and dolutegravir is rare, which we know. And these drugs have high barriers to resistance. And so that makes sense why these are the sort of same day start recommendations. And they specifically say, don't start dolutegravir 3TC if you're going to start them that day. So I wanted to ask the group, this is why I was really excited for Poll Everywhere with all these questions, but how do you feel about the updated DHHS guidelines to consider dolutegravir 3TC as an initial regimen for most people? Are you thinking, I love this, it's about time? Is it, I'm ambivalent, I'm skeptical, I am opposed to this, or I don't yet know how I feel about this, and expect that Jihan will guide me there? So who is super excited about this? Bob, I was expecting that. Okay, you know I'm going to pick on you and ask you about that later. I am ambivalent. Anyone? Okay, nobody's ambivalent. I am skeptical. Great, we've got David, and Brian, and Anne. I didn't see Nina's arm. I'm opposed to this. And I don't yet know how I feel about this. Okay, so I think that's great. I think what's nice about sort of HIV medicine and medicine in general is that there's actually a fair amount of data, and my hope is to share some of that data, and then you sort of make a decision on what you're going to do with that. And I do not want to spoil you, but I do want to hear Bob's take, because I know Bob loves 2-drug therapy, and so you're really excited about this. Can you share?
I think I've been impressed with the long-term toxicities of nukes. I think that we always think that the latest nuke is going to be the answer, and then 2 years later we're upset with that. That was true for D4T, that was true for DDI, that was true for tenofovir, and who knows what's in store for TAF 2 years from now. The one NRTI that's we've used forever and really has limited to no toxicity is 3TC or FTC. So having that kind of a nuke light, along with a very potent drug with high barrier to resistance like dolutegravir, makes sense to me. And there's prospective data comparing those 2 drugs with a standard 3-drug regimen. It looks like it's just as good. So we do have prospective randomized data suggesting it works. And theoretically, you're avoiding all the toxicity that might be associated with other nukes. So I'm a fan.
Thanks, Bob. Bob was a plant. Just kidding. But I'm going to actually talk about those RCTs. You guys have seen some of these slides before. Thank you, Brian and David. And so this is sort of the study that Bob was talking about, which is the Gemini study, where they randomized people to dolutegravir 3TC versus triple ART. And was, again, sort of a non-inferiority RCT of about 1,400 people, as you can see. And these were the enrollment criteria. And I wanted to have people sort of hone in on the fact that these were treatment-naive adults, that the viral load was anywhere from 1,000 to 500,000, and that's a pretty high viral load. That there were no NRTI, INSTI, or major PI mutations, and that there was no chronic Hep B. So these are the baseline characteristics. Aside from the fact that it's mostly sort of young white men, I wanted to highlight the bottom, where it shows that the people who had a CD4 count less than 200 were a relatively small group, about 63 or 55, and only about 8 or 9% of the study had a CD4 count less than 200. And that if you look at the viral load, that most people had a viral load less than 100,000, that's 80%, versus about 20% who had a higher viral load. And the week 96 data for Gemini. Sort of this is stratified by baseline HIV RNA level. On the far left is pooled data, and then on the right, the two show the viral load based on less than or greater than 100,000. And then the percentage, or the y-axis, is the sort of RNA that's undetectable. And you can see sort of throughout the board that blue being DTG3TC versus green triple therapy, that it was non-inferior. So regardless of the viral load, dolutegravir lamivudine was non-inferior to triple therapy, which was dolutegravir, tenofovir, DF, and emtricitabine. So that's great. But then this is a sort of an area of concern. And this is, again, sort of the similar data, but based on CD4 count. And on the middle, you'll see that there's really no difference if your CD4 count's greater than 200, but a pretty darn big difference, nearly 20%, if your CD4 count is less than 200. Again, I just mentioned that this is a small number of people, but that's still about 60 people in this dolutegravir 3TC arm who, like 68% of whom did worse with a CD4, with their sort of virologic suppression. So what about dolutegravir and 3TC in the real world? We don't actually have that much data for this because it's relatively new. And so the only thing we really have is a poster from the European AIDS Conference this fall. And this was sharing information of the, I'm gonna call it the VATCH clinical cohort, which is a retrospective clinic-based cohort study in Spain over 3 years. And they looked at people in their clinic who were either already placed on dolutegravir 3TC or dolutegravir rilpivirine versus people on triple therapy. So 600 people were on dolutegravir-based dual therapy and 5,000 people were on triple therapy. And then you can see sort of what those triple therapies were, either Triumeq or Genvoya. And then their endpoints were the following: time to discontinuation due to failure, risk of discontinuation due to virologic failure, and a couple of other things, including adverse events. So the sort of baseline characteristics of this group, again, this is a sort of a cohort or a retrospective, or this is a cohort study, so it's not like matched by any means. And so they're relatively young, again, 48, 52, mostly men. And then focusing here, most people had good immune response. Their CD4 count was high. Most people had virologic suppression, 80 to 90%. And then most people had been on ART for a long time, so about 12 to 15 years. And then most people had been on many medications in the past, 5 to 7, and had had an episode of virologic failure in the past as well. And then these are their results. In the sort of on the far left is probability of remaining free of treatment failure. And then on the right, or on the x-axis, is years from switch. The blue is the INSTI-based triple therapy, and then the red is the dual dolutegravir-based therapy. So again, either dolutegravir rilpivirine, which is Juluca, or Dovato. And as you can see that they sort of move apart, that the dolutegravir group had a little bit more failure as opposed to the people on triple therapy. So their summary, which again, it's hard to get really good sort of details about this because it was from a poster, but they found that people with HIV switching to a 2-drug regimen had more than a doubled risk of discontinuation due to treatment failure, that there was no difference between the regimens in discontinuation for adverse events, and so thus they concluded that there were more treatment failures in those switched to dolutegravir rilpivirine or dolutegravir 3TC as compared to INSTI-based triple therapy. So before I sort of go into the next sort of poll, I just did want to mention that this is not exactly what the sort of guidelines are saying. The guidelines are for most people starting ART. This is of a cohort of people who are relatively treatment experienced, so different group. But after you've seen that data, how do you feel about considering dolutegravir 3TC as an initial regimen for, quote, most people? You still think it's great? You remain ambivalent, skeptical, or opposed to this? And, or maybe you've changed. So, Bob, do you still think this is great?
Well, I have a question for you. In that last study, for the people that failed, for the people that failed, do they have drug resistance data, and did they fail because of that?
Presumably they have drug resistance data, but that was not in the poster or on their abstract.
and also the group in this, they did have more treatment failures in the past and more regimens in the past. And so, you know, they were, the sicker people got the 2-drug regimen compared to the 3-drug regimen. So I don't know that sways me very much. And I think if you choose your patient properly, the answer to your poll is that if you have somebody that doesn't have Hep B, that their viral load is not crazy, their T cell count is not crazy, I think 2-drug therapy is still a good option.
Thank you, Bob. David, are you ambivalent? Do you think it's great? Or do you still skeptical?
I actually agree with everything that Bob said. But I'm not in the same category only because I think the guidelines frame this wrong. Because if you're going to say on one hand, you need to rapid start everybody and you need to wait till a genotype comes back, that's a 3-week period, and that then excludes you using a rapid start. So I'm actually really excited about the 2-drug regimens. I just think the guidelines kind of put us in the position, and they're framing it in a way that we probably practically wouldn't use it. But I think we should be, and I think the way that study used it in people who have long-term history and may have multi-drug, that's not the right place to use it either. It's somebody who has pretty clean genotype and they start on some regimen, you could easily step them down to long-term, because I'm not worried about a month or two of TAF or TDF. It's like Bob says, you know, the toxicity issue could be more longer term. So I think it's just a matter of how you frame it and what you're excited about. But I think the way the guidelines have done in our push to do rapid start, it's made it kind of hard to do this up front.
Nina, I saw your hand go up.
Yeah, I'm still in in the category, the skeptical category, and largely it's because you know, I'd like to see real world data with this. I mean, this is, you know, people who, you know, select in for randomized control trials may be different from, you know, just our regular different patient populations with all their heterogeneity, particularly with respect to adherence. So that's mainly why I kind of like to see. No, I agree with all the points made by David and Bob that, you know, you want to select these people carefully, but I also still like to see some more real world data on 2 drugs.
Yeah, I mean, thank you, everybody. I think what's interesting about the sort of this batch clinical cohort is these are essentially people who do not meet the inclusion criteria for the SWORD, which is the sort of RCT that got dolutegravir rilpivirine on sort of the board, and the Gemini studies, right? So these are people who are failing those inclusion criteria, because for Gemini, you had to sort of be ART naive, you can't have had failure before, or you can't have had resistance before. So this batch clinical cohort was people who had been on medications before, so this was not ART naive. And then similarly with dolutegravir and rilpivirine in this clinical cohort, SWORD was people who had only been on, I think, 2 ARTs beforehand, had never had failure. And so it's very different. This real world stuff is very different than what was in those inclusion criteria. And I think the other, I mean, I don't run RCTs, but Anne does, and you can talk about it. But I think that sort of someone's engagement in an RCT is not necessarily real life. And especially if somebody's giving money or if there's incentives to sort of be in the RCT. Again, I think I'm with Nina in that real world data would be nice. And I think for me, well, actually, let me just, so let's have a hand raise, because we heard some people and we heard people swaying. Can you raise your hand if you think it is great? Bob? Ambivalent? Okay. Skeptical? And I'm opposed to this. Nobody. So I'll share that, like, sort of, even just going through this, I changed from I am opposed to this to I am skeptical, and I'll explain why. I think I am not opposed to dolutegravir and 3TC, as Bob said. I also haven't seen that much like nuke toxicity just because I haven't been doing this as long. But I am actually opposed to how the DHHS guidelines put it in there. I think that, as David mentioned, I think that it should not be in the for most people, but should be for in certain clinical situations. And I think that the fact that they didn't include the CD4 count in there is interesting. I recognize that that was just a small percentage of people. It was what, about 10% of people in this study had a CD4 count less than 200. But if there's that signal where people are not doing as well with that CD4 count, why, when there are better medications, until I can get someone's T cell count higher, would I choose to do that? And I think that I'm disappointed that it wasn't in there. And I think another worry that I have about it being in the most people section is that unless you're, I mean, I don't always read fine print. I think it's human nature to not always read fine print. And so I just worry that if someone is just looking and they see that and they get excited, this is new, I'm going to start it, without sort of reading all those caveats, without having the CD4 caveat, I am skeptical. So yeah, other thoughts on that? Okay. So first off, I wanted to say thank you everybody for participating. And just to conclude, rates of INSTI transmitted drug resistance are low. We've reviewed that. And how does this affect your practice of checking baseline genotypes? We talked about that a little bit. I don't know if it's necessarily going to change my sort of practice, but I rarely get it. There may be some situations in which I still rarely get it, especially if somebody has a partner who has HIV, knows who they got it from, and suspects that there may be resistance. So that is important to ask sort of who their partners may be, and if they're on ART, if they're virologically suppressed, if they're missing their doses. That same-day ART start is aspirational but resource intensive, and I think in the DHHS guidelines it even says it's like this is lacking more RCT data in America, et cetera. And so I think people have talked about this as well, that we need more data in the US and to answer whether it affects virologic suppression in the long term. But I don't think that there's a downside to getting people on ART as soon as possible, especially if there's this like emotional attachment and excitement about being on the ART. As Bob said, it's less about the sort of clinical or like sort of effect of the viral load and more about like, is it keeping people engaged in care and how it affects retention in care in America. And then if you're going to start dolutegravir 3TC, be aware of the inclusion criteria from the Gemini study and consider real world effects. I think not just for this, but I think in general, when you're looking at medications and trying to start off with something new, I think it's really important to look at inclusion criteria, randomized clinical trials, and to remember that it's an RCT and not real life. And that I would beware use of those, or use of Dovato in those with a CD4 count less than 200. I added that in there since it wasn't in the guidelines. So that's it. Any other questions or thoughts?
For those of you who don't know me, I'm Susan Buskin from Public Health. So I'm sticking my head out at the risk of being a lightning rod here. And
Thank you.
I just wanted to speak on behalf of, yes, please do a genotype. Yes, please start antiretrovirals right away. And the reason why I'm saying these things are, we have this new initiative. We're trying to end the epidemic. One of the 4 pillars that we have that the CDC is promoting us to do are looking for recent and rapid growth in HIV. And one of the tools we have to do that with is looking at genetic relatedness. And I'll just give one more plug here that on our website, we have information about local integrase resistance.
Oh.
And we've seen about a 3% rate overall. I'm talking about experienced and naive. And unfortunately, I just looked at our website. The data is really crappy for transmitted. We just looked at people who had a test within a year of diagnosis. So today's talk makes me want to go back and find out, the timing of antiretroviral start versus the resistance. But we've had 12 people with integrase resistance based on the Stanford interpretation who had a INSTI genotype within a year of diagnosis. So, 12 is not a huge number. We can go back and look to see whether it was transmitted or acquired. So anyhow, a little plug for our website and a plug for genotyping.
And I definitely think, I'm still very much getting RT and protease genotyping that's still in the DHHS guidelines. I know that there is some buzz about whether or not it needs to be done, but I'm following what Susan says for the time being, and until we have more data or until you guys change your tune. But I doubt that will happen.
Question from the web, Jihan. Yeah. What about insurance covering these newer 2-drug regimen?
Oh, I mean, that's a great question. I haven't had issues with Juluca. I have not prescribed Dovato yet, which is Juluca, dolutegravir, rilpivirine, which has been out for a little bit longer than this one. Has anybody gotten into sort of tricky situations with insurance coverage for 2-drug therapies?
I think Jaluka's not a slam dunk.
And has anyone tried to prescribe dolutegravir 3TC? Brian has?
Not for initial start, but
Okay.
switch maintenance. And it was not covered.
Not covered. Okay. So then thank you to the person in the web who asked this question, but it sounds like sort of may have some difficulty or not covered. And were you able to get it covered through a prior auth, Brian? Do you know? Or just like absolutely not?
No, but I had other options in this situation, ended up going a different route.
Okay. Okay. Thank you. Okay. Thanks, everybody.
Good job.
Oh, thank you. Thank you.